Preparing to go live. Okay, great. Good night, everyone, and welcome to tonight's Q&A session. My name is Adelia Thomas, founder and director of She Is Lotus. Welcome to the third in our series with the Center for Endometriosis Care and with Dr. Eugenio Colon. And tonight is our Q&A session. And Doctor, we have had questions being sent since the end of the last session, after we announced that we'll be having a Q&A. So we have a long list of questions for you, and I'm sure that the persons who are live right now also have questions for you. So I'll be moderating the questions that have already been sent in. Alicia is moderating the Zoom chat questions, and Kimet is moderating the Facebook Live questions. So good night, everyone, and welcome to tonight's session. I hope that it is informative and helpful to you. And again, we have with us Dr. Colon. He needs no introduction because this is our third time having him, but we still want you to know who he is if you are new and if you come upon this live later on. So this is Dr. Colon, a board-certified high-volume surgeon at the Center for Endometriosis Care, who specializes in laparoscopic excision of endometriosis and advanced minimally invasive gynecologic surgery. He rejoined Dr. Sinova at the center in early 2023 from his role at as the director of the SLU Center for Endometriosis and an assistant professor in the Department of OBGYN and Women's Health in the Division of Minimally Invasive Gynecologic Surgery at St. Louis University School of Medicine. A foremost endometriosis advocate, which we love and appreciate, with an interest in improving the landscape of care through his vast efforts. He is also especially dedicated to improving medical access in under-resourced and the Latin American communities, and to that end, continues to serve patients in the Dominican Republic as well, where he is part of the EFS Gynecology and Obstetrics team in Santo Domingo. Dr. Colon continues to teach globally and has trained many other physicians in the meticulous excision of endometriosis, including from the diaphragm, ureters, and other vital organs. He has contributed to countless publications and research studies on the disease and is renowned for his sincere compassion, patient dedication, and disease expertise across the global endometriosis community. And we here in St. Vincent and the Grenadines love him just as well. And so, Doctor, we are getting into the first question. And this question came since the end of our last session when we announced that you'll be back for Q&A, and it is from Liliana. And her question is, what is the actual connection or statistics between cancer and endometriosis/adenomyosis?
So endometriosis has been, to my knowledge, adenomyosis has not been linked to increased risk of cancers, of uterine cancers per se. If that would have been the case, then recommendations would have been a lot more stern about as soon as you were not thinking about having kids to undergo hysterectomy, but that's not the case. Now, there is a slight, some studies have shown a slight increased risk in two types of cancers associated to endometriosis, which is endometrioid cancer and clear cell adenocarcinoma of the ovary, if I'm not mistaken. So those two are the only ones, but again, it's a slight increase. But we don't necessarily tell patients that, hey, you have endometriosis, so it may increase your risk, like you may have a higher risk of cancer, so we need to take the ovaries out, right? No. That's not how necessarily we associate things. But think about this. Endometriosis contains glandular tissue that actually have glands that are can be activated by hormones, right? So one of the things that happens is that one of the favorite treatments of many OBGYNs in the US is it's to do a hysterectomy on a patient that has endometriosis, which has disease outside of the uterus. But then again, take out the uterus, the fallopian tubes, not the ovaries, but leave all the endo there. So they leave the endometriosis back. The patient after the surgery continues to having pain. The patient comes back to the office and says, hey, doc, like I'm having a lot of pain. and they go like, I don't know why you're having pain. You don't have a uterus. You should not be complaining. Go somewhere else. And it's kind of a way to kick patients out of the practice after they already taken in the gravy, right? Like they took out the uterus, took out the fallopian tubes, and that's it. Leaving all the disease. And we see that so often, like when we see, which is why when patients come to talk to us, I don't care about like anything that they wrote down. If I have pictures or videos of the surgery, that's all I care about. Because it doesn't matter what you write, it matters what I can see and deduct for myself based on what they did in your surgery. So one of the things that we do here is we give patients a lot of before and after pictures. And we sometimes give, if patient requests, we give them a video of their surgery so that they can sit down, take a look at it later, or take it somewhere else to get evaluated if they choose to do so, right? So when some of these patients get a hysterectomy and they leave this disease that's outside of the uterus behind, what's end up happening is that they have an ovary, and that can actually, their own patient's own hormones can actually allow the endometriosis to continue. That's one thing. Second thing is the reverse, and then something else happens. Some patients actually get a hysterectomy, and on top of that, they get a surgical castration. And I use that word on purpose, so it has an impact. We're castrating 20. I saw a patient this week that was 26 years old and was castrated like a dog. So she has horrible endo, and instead of treating her properly, they decided, you know what, no kids, no nothing. Let's take out your uterus and then take out your ovaries. And they castrated her, a patient that wanted to have kids, right? So in this case, like we should have deep conversations with patients regarding these things so that we're preventing surgical castration. Now, what happens is that after they take out the ovaries and the uterus and they're castrated, then they feel really bad because when the patient comes back talking to them, hey doc, like my uterus is out, my ovaries are out, I'm feeling a little bit better. But then they complain and say, but now I have all the symptoms of surgical castration, right? Like taking Lupron or Lissa for a long time, which are low libido, dry vagina, loss of hair, hot flashes, like moody, dead husband, everything, right? So then what happens? They feel really bad that they have a 90-year-old vagina, and then suddenly we feel bad for you, so let's give you estrogen, which is bananas, right? It's bananas. Like, so they take out the uterus because the uterus can actually cause a significant amount of pain, or because it could be related to endometriosis. But then they take out the ovaries, and on top of that, after this, they put her back on hormones. So what was the reason of taking out the ovaries in the first place? Right? So that is one of the things. So if you have a patient that's taking hormones for a very long time, which I saw a patient last week that was taking, that had surgical castration, and then 10, 15 years later, she's been taking unopposed estrogen for years, right? And we do know that unopposed estrogen for a long period of time has been linked to endometrial cancer. So it stands to reason that if you have endometriosis outside of the uterus and you have glands that are constantly stimulated because of the estrogen, that you have a slight increased risk of malignancy, right? Which is why when there's recommendations for patients to use hormones, we go, yeah, you could use hormones, but for a very short amount of time, not for 5 to 10 years. That is what we see a lot of patients getting hormones.
Sorry, I was muted.
That's okay.
Thank you for that answer, doctor. And our second question is from Rafaelina. I hope I'm pronouncing that right. I was diagnosed with endometriosis 2 years ago. When my period ends, I still have pain for more than 10 days, especially in the back and after going to the bathroom, as well as pain in my pelvis. Is this normal?
So pain is the number one indicator of the body to tell us that there is something wrong with the body, right? A patient today asked me, like, so after surgery, how do I know that if I need to have another surgery? And I said, well, pain is your number one indicator, right? But what we do know is that when we take from what I've learned from my training and from everything in life, is that if you only focus on treating the endometriosis, you're focusing on losing the battle, right? Because endometriosis is only one of the things in the pelvis that can give you pain, right? What do you have in your pelvis? You have your bladder, right? You have your uterus. So if we divide it, and it's something, I usually do a diagram for the patient in the office and when we talk to them, and we go, okay, so what are the things in your pelvis that can give you pain? So we go GI, so chronic constipation, chronic diarrhea, inflammatory bowel syndrome, ulcerative colitis, Crohn's disease, small intestine bacterial overgrowth, right? So there's many different things from the GI standpoint that can give you pain. You can have intestinal volvulus. You can have altered transit, like slow transit, GI transit, which can actually cause bloating and all these things, right? That can actually be exacerbated when you are in certain periods of your cycle, which is why when progesterone is doing its thing in your body, bloating happens because which is what happens to pregnant women, right? When they have a lot of progesterone and a lot of fluctuations in progesterone, they get super bloated, like in pregnancy, right? Which with some of these patients end up having horrible constipation because the intestine just stops, right? So that's only from the bowel standpoint. So in the evaluation of our patients, they need to do what? Depending on their complaints, we make sure that we're making individual modifications to their treatment. So they have to usually see, depending on the questions that I ask them, they have to see gastroenterology, they have to see colorectal, sometimes depending on what the issue is. And they sometimes some patients can actually need to have an evaluation for defecatory dysfunction, right? Because you have your anus, it's part of your pelvic floor, and you have your rectum. But when the rectum is dilated, it tells you, oh, I got to go to the bathroom. So in order for you to defecate, you have to squeeze the rectum and relax the anus. But sometimes you have chronic tetanic contraction of the anus because you have chronic pelvic pain. So the only thing that you can manage in the bottom is what? Your pelvic floor. So your pelvic floor is doing this constantly for hours, weeks, days, months, right? So you're trying to literally poop on a very tightly closed anus. And when you have contractions or tetanic contractions of their anus or pelvic floor, some patients can sometimes experience proctalgia fugax, which is one of the questions that I saw earlier in the chat that Sarah Abbey actually mentioned. Proctalgia fugax, Sarah, correction, is not a diagnosis of endometriosis, but patients that sometimes have this and have there's no how should I say this? So there's not 100% prediction that if you have proctalgia fugax, you have endometriosis, but patients with proctalgia fugax have been seen to have endometriosis in the past, but they're not directly correlated, right? Because you have a massive tetanic painful contraction that happens, and it sometimes feels like somebody's stabbing you up the anus. So it's very sharp pain that could last for seconds or for minutes, and it comes and goes at different times throughout the day. So it can be cyclical. It can be actually more related to your cycle or not, but having one thing does not necessarily mean that you do have endometriosis or that you have bowel endometriosis per se. But I have had a great deal of patients that do have evidence of proctalgia fugax, and after endometriosis surgery, with or without bowel resection, that significantly improves. So the direct mechanism is not necessarily well understood, but I know that if you have something in your pelvis that causes chronic inflammation and chronic pain, all your pelvic nerves are going to be heightened, and then you can have tetanic contractions on the anus and some of these areas that can actually be perceived as proctalgia fugax. Okay.
Thank you. Next, and this is from Matty. How to determine beforehand if you need a VATS or not?
Oh, that's a good question. So in our center, we have the privilege to do an incredible amount of thoracic endometriosis and to have a specific team with Dr. Goldman that I think it's the most experienced cardiothoracic surgeon in the country, because we do, and the center does around 3 to 4 thoracic endometriosis cases a week for the last 10 plus years, right? So the amount of experience that our team has evaluating patients for thoracic endometriosis is severe. It's extensive. Now, if you have a catamenial pneumothorax, that's a very high likelihood that the reason for the catamenial pneumothorax is actually endometriosis. Now, when we're doing the evaluation for patients with thoracic endometriosis, we ask them very specific questions about how are their symptoms of chest pain or rib pain or pain behind the nipple. Does this pain refer to the neck, the scapula, or the upper back, right? Some of these questions kind of guide us having a better understanding of where are these lesions, where some of these lesions can actually be located, right? And that's super important. Let me see if I can show you a video.
Thank you very much, doctor.
Wait,
And
so,
then,
so that I continue with that question. So it all depends on those things can kind of give us a good idea of where are they located, because it could be very different depending on where the symptoms are. If the patient is actually having symptoms more anteriorly, you're actually thinking about more of how the diaphragm or how the nerves are actually involved or going from the back towards the front. So usually between each rib, right, you have what's called the van. So V, vein, A, artery, and N, nerve. So under each of your ribs, you have literally, between each of your ribs, you have space. And in that space, you have the VAN. So just like that, vein, artery, and nerve. So depending on where you're having the pain along your wrist, you can feel your ribs, you can feel actually pain that's behind your nipple or a little bit more posteriorly. Some patients that have extrapelvic endometriosis in the upper abdomen or right under or above the diaphragm, depending if it's in the front of the diaphragm, the back of the diaphragm. If it's more towards the back or what we call the central tendon, patients can actually have pain that refers a little bit more to the scapula directly back, but it also depends on where it is. So one of the things that we use to evaluate patients is we do pulmonary function test just to make sure that they're able to withstand the tube and all these things for surgery. And then we do sometimes MRIs or CT scans so that we can see the dome of the diaphragm. But this is important to understand one thing. These tests are not meant to tell us if you do or do not have diaphragmatic endometriosis. They're actually meant to guide us on how extensive it will be. You can sometimes have diaphragmatic endometriosis or nodules of diaphragmatic endometriosis that are very small, but they're close to the phrenic nerve. So phrenic nerve is a nerve that's originated in your neck and goes down around the esophagus and the heart and goes into what's called the central tendon of the diaphragm and spreads like a spider web to the right diaphragm and left diaphragm. So the nerve, it's actually, let me see if I can do this for you guys, 1 second. So the nerve, do this, it's gonna be 1 minute. Let's Dr. Google something real quick. So, let's see, it's this one. So let's Dr. Google something real quick as a group. So phrenic nerve, let's look for images. So it's a nerve that actually comes right here around your neck, C3, C4, and C5, goes around the esophagus and heart and goes into the diaphragm itself.
Excuse
So,
me, doctor, we're not seeing anything on the screen.
oh, you're not? I'm sorry.
Blank, yeah.
Not
Okay.
Yeah.
So,
Might have to come out and come out of screen sharing and then go back in. Because it's just it. Ah, there we go. Seeing you now. All right.
okay, good. Sorry about that, guys.
No problem.
So let's see. So this is yeah, this is a good picture. You guys are seeing the picture on the left side
Yes.
over here.
Yes,
So
please.
you have basically the phrenic nerve comes from C3, C4, and C5 all the way down around the throat, going down around the heart and the right of the heart and the left of the heart. And they insert themselves at the level of the diaphragm down over here, midline. So if we look at quickly, diaphragm anatomy. Let's see, we can look at the diaphragm, this picture, this is a good picture. So now we're looking at the anatomy of the diaphragm. So the diaphragm is coming, it's right here at the dome of the abdomen, and it separates the abdomen from the thorax up here. So the phrenic nerve goes into around the heart on the right side and on the left side. Is that a good, are you guys seeing, is it a good picture there? right? Is that better?
Yes.
So now you see basically
Yeah,
this is, we're looking at the diaphragm from down to up. So imagine you're under the patient looking up, like up under the diaphragm. So you would have over here the big, some of the major vessels that are in your diaphragm, but you can see how the heart would be in this center spot, right? And then you can have the vessels and arteries that are feeding the diaphragm, both to the left of the diaphragm and the right of the diaphragm. But you see these yellow marks right here, close to the blood vessels, right? These are the nerves. So the nerves in the diaphragm are actually really closely following the vessels. So if you have a disease on the diaphragm itself, you can have pain that's referred up towards your neck and your shoulders, right? But if you have the disease that's actually on the outer edge of the diaphragm and not central, you may have disease that's actually affecting more your ribs, and that is kind of a different type of distribution. So that's kind of the difference. That's why we're very specific when we're asking you questions about the disease or where does the pain go and how things look. So that way we have a much better specific idea of where to look for at the time of your surgery. Okay.
Yes. Thank you so much, doctor. This is so educational for me.
Awesome.
Yes, thank you. And the next question, what is the reoccurrence rate of endo in patients with endometriomas after excision surgery?
So unfortunately, that's more surgeon specific. So it depends on the technique that the surgeon used. It's one of those things that, like, depending on how aggressive your surgeon was, depending if you want to get pregnant in the future or not, sometimes you sacrifice how you modify the way that you're cutting out the disease, taking into consideration the patient's fertility rate, right? So what happens? When a patient gets an endometrioma, the endometriotic cyst grows on the inside of the ovary. So that cyst can cause inflammation, which can be acute and chronic. But in the same ovary, this patient is also ovulating as well. So as these eggs are growing inside of the ovary, because of the environment of chronic inflammation that they are, the quality of the eggs is significantly decreased, which is the fight that we usually have with infertility doctors that are more focused on getting you pregnant. But then as soon as you're pregnant and you're done, and then you have diaphragmatic endo, rectovaginal endometriosis, rectal nodules, they're like, we don't do any of this. Go somewhere else. So, and I understand that it's a different focus, right? Because their focus is to try to get you pregnant at the time, right? My focus is to make sure that you have a good life for the next 50 years. So, and understanding that I do want you to be a mother if that's your goal, but I also am hyper focusing on the quality of life that you will have for the next 50 years. One of the things that I tell my patients a lot is that if you have love in your heart to give to want to be a mom, you could be a mom to a 2 or 4-legged child. Right? So my goal is to make sure that if you want to get pregnant, try to get you pregnant. But my number one goal is always to make sure that we improve your quality of life. So when patients have endometrioma, even though they're small, my number one thing is let's go and remove them, because a small endometrioma, it's a small problem. A big endometrioma, it's a horrible problem, because when it breaks and it leaks and it sticks to everything, then we end up doing a multi-hour surgery, putting you at risk, right? And having all that fibrosis dig into your pelvis, so that we then have to do what? We then have to cut some of the nerves that are going to bladder, bowel, the splanchnic, like it just digs into everything. So then when you have endometriosis going into your sciatic nerves or sacral nerve roots, then what do we do? Right? So that's the importance of treating endometriosis early. Like, and if you have endo, like, we also need to evaluate all your other female family members so that we're taking care of them early, because it's so easier to do an hour surgery than to do a 9-hour surgery when you have endo in your diaphragm, and then you end up with a colostomy or something like that is very detrimental to your health, right? So that is the importance of taking care of these things earlier.
Thank you, doctor. I am a firm advocate for quality of life based on my own personal experience with this disease.
Okay.
I would always choose that.
Yeah, I understand, but I also wanted to take the time to show you something real quick here.
Okay, no problem.
So when we're looking for diaphragmatic endometriosis after we do the surgery from the bottom, then we have our team go from above the diaphragm and look down. So it's a double approach. We have me and Dr. Cerner looking from the bottom, cutting out everything we can from the bottom. And then we have another surgeon, Dr. Greenside, going from above, correction, Dr. Goldman going from above the diaphragm, looking down. So it's a double whammy approach, right? So when we're looking from top to bottom, sometimes we are able to find even more disease that we're not able to see from below, right? So for example, in this picture that I'll share with you guys now. In this picture right here, what's happening is that we're looking, this is the lung. So this patient has a camera between her ribs, like lateral to her breast over here. And we're looking from the top down at the dome of the diaphragm. So this is what we call the central tendon of the diaphragm, right here, right? And there's a lot of nerve endings here going into the muscle of the diaphragm. Remember the picture that I just showed you, where the nerves go into the central tendon and then spread laterally like spider webs into the whole diaphragm. So then this happens, right? You have that some of these patients can have holes in the diaphragm, right? And then when they're having a period or there are lots of hormonal changes, this portion of the diaphragm actually, when it also inflames the bottom of the lung, you have air escape and you have a collapsed lung, right? The chest cavities are a vacuum. And that allows the lungs to expand and contract based on the air that's on the inside, right? So if you have a leakage of air from the lung into the chest, then that basically creates a pneumothorax, and which could actually, depending on the amount of air that's going into the chest, it could actually be a tension pneumothorax, which could actually be life-threatening. But some of these holes are experienced from the top. So sometimes it's very difficult to remove some of these holes from the top. So you have to do a VAT so that you can staple. And in this case, unfortunately, we have to do a really wide excision of all these area over here, which means that the patient can sometimes lose a little bit of a breathing capacity, right? Because some of the nerves that are going to all the diaphragm are actually affected, and that's going to be detrimental. But we have to, because the opposite isn't, it's worse. Not removing that and having multiple pneumothoraces throughout her life, ending up in the ICU. I saw a patient the other day, which I consulted while she was in the ICU in New York, that she had 4 or 5 pneumothoraces that were just happening every other month. And she's like, I need to take care of this. So that hopefully we're able to see her soon and help her in her journey.
Yes, I hope so too. That must be so scary for her as well.
Yeah, it's horrible. Like that causes what? That causes extreme anxiety, depression, suicidal ideation, because you're like, oh God, I'm gonna get my period and I know what's gonna happen. And you get your period and 3 days later, you can't breathe, you have chest pain, you feel like you're having a heart attack, you go to the ER, you're desaturating, you know, and things can get worse.
It's from a personal, it's terrifying. Like you're afraid to fall asleep at night because you think you're gonna in your sleep. It's not fun.
Wow. Okay, next question. They're asking for some tips from you, doctor. Tips to make bowel prep more tolerable for sensitive stomachs ahead of excision surgery.
That's a question that we get a lot, but it depends on what works for the patient. Sometimes one of the things that we do is, if the bowel prep, if they're not able to do bowel preps, we kind of modify them. Sometimes we do the bowel prep, like for a colonoscopy, we do the whole jug of Go Lightly, or we do the Miralax. And now we're working with our colorectal team, and they have their own, which actually they have their own different bowel prep instructions that we were talking about and discussing it earlier today. And I had it with me right now because I was reading it. I can't necessarily find it, but I did. But it all depends on the surgeon. So they're kind of surgeon specific, right? One of the things that we do sometimes in patients that cannot have a bowel prep is that whatever works, we instead of starting the bowel prep the day before, we start the bowel prep way before surgery, like 2 to 3 days, and then just have them on a liquid diet, on a clear liquid diet for 3 to 4 days before surgery. So hopefully there's nothing there and they're kind of pooping a little bit more normally until everything comes out and more clear things are coming. But the problem is that some patients are not able to tolerate the medications, or they can have severe pain, fainting, because they can have obstructions. So that can cause like their pain to go elevated. So we're very sensitive about those issues. But sometimes I have to coordinate what I want to do with what colorectal wants to do when it's a combined case, because it varies from patient to patient. And there's so many different formulas that something may not work for one patient, but it may work for others.
Yes. I like the individual approach.
It has to be, right?
Yes. And so we have a next question. This is from one of our Caribbean sisters. And her question is that she had diagnostic laparoscopic surgery in April, and she was told that she now has stage 1 endo. This is after suffering from heavy periods, debilitating pain, chronic constipation for more than a decade. She was told that the surgery went well, but she still suffers from chronic constipation and urinary incontinence that has disrupted her life to the point where she has to organize her schedule around her bodily functions. The bowel and bladder area was deemed too risky by the surgeon to operate on, because this would mean open surgery, and so they did not venture there. She is now at a loss as to what she can do to manage this. She already tries to manage her constipation by eating lots of fiber and avoiding gluten, but she's at a point where she cannot have bowel movements unless she takes laxatives daily. She is now at a loss as to what she should do going forward. Does this mean she needs another surgery? She feels that she's doing everything right and she is a failure.
So first of all, she is not a failure. Okay, that's the first thing. She's not a failure. That's the first thing. Second thing is, it all depends on multiple. It's just so hard to give her a straight answer, because I would have to ask her my 50,000 questions regarding her bowel and her options, so that I can have a much broader idea of what's happening to her, so I can give her a proper recommendation. But one of the things that struck me as a little odd is that if you have stage 1 endometriosis, and on top of that, they're telling you that they don't want to venture in those areas because you're going to have open surgery, it doesn't really sound to me like you have stage 1. I mean, call me crazy, but it doesn't really sound to me like you have stage 1. So, which is the importance of having pictures and videos. But I mean, why? I mean, the bladder is such a nice organ to cut and suture together. So if there's disease there, it has to come out. It doesn't matter if it's in a dangerous spot or not a dangerous spot. Once you talk to the patient and they understand the three syllables, which are risk, benefit, and 2 syllables under vowel, and the alternative, right? Risk, benefit, and alternative. Once they understand these 3 things and you explain in detail these 3 things, because I talk to my patients for an hour and sometimes an hour and a half, right? So I want to make sure that they understand risk, benefit, and alternative. And on top of that, the risk and benefits of the alternative, so that they can make an informed decision, which is when I love it when patients tell me like, oh, I read in Google, I take out my tea and I drink. What's up? What did you hear? Because it's a good opportunity to discuss, to figure out if what you read was accurate, or how can we change your opinion, but giving you actual factual data. Right? So that's the importance. Now, in her case, urinary incontinence, it all depends on what age she is. If she's having urinary incontinence, because it could actually be because she has a functional problem of the bladder, or she can have nerve damage from endometriosis in her hypogastric nerves that are affecting her. She definitely needs to see a skilled urologist or urogynecologist in painful bladder syndrome and urinary incontinence. So there's multiple problems that are in that sentence that need to be addressed. So it's not only endometriosis, which is why I send patients to urology, urogynecology, pelvic floor physical therapy, to gastroenterology for colonoscopies, motility studies. It's more than one thing, right? So in her case, I think she needs a much more extensive evaluation. And depending on what they saw at the time of her surgery, if they left some stuff behind, definitely the option is go back and take it out. Find somebody that would go back and take it out.
Yes. Thank you, doctor. I only have 5 more present questions and then we'll move into the life questions.
Got it.
What causes hemorrhagic cysts to keep reoccurring?
Oh, that's a great question. That's a great question. So one of the things that I tell my patients often is that the function, what is the function of the ovary? Anybody? Kasara, anybody? What is the function of the ovary?
To make cysts.
Exactly. Great. So so we produce sperm inside of our testicles. You guys produce your portion of the baby, right? Inside of the ovary, producing a cyst. So a cyst, as it's growing, it's producing one hormone before ovulation. That hormone is estrogen. And estrogen, basically, it's a beautiful hormone, makes things grow, breast, eyebrows, and according to my wife, intelligence. So all this estrogen in your body is doing its job. Now, what happens? When you ovulate, the cyst ruptures, right, and releases the egg. So now the cyst goes from a follicular cyst, it changes to a progesterone-producing cyst. But the problem is that because the cyst ruptures at a random area, the cyst can actually bleed internally, and a clot, as the cyst and the ovary regresses, the cyst continues to bleed internally. So you have a hemorrhagic ovarian cyst. So that is luck of the draw. Some month you may have a hemorrhagic ovarian cyst, some other month you may just have a regular corpus luteum, or then which degenerates into a wide body or corpus albicans. But it depends, like it's just luck. Some women would have a hemorrhagic cyst every month, which it's not a good thing, or it's not, it could be because it can cause a lot of pain. And then, you know, our partners are sometimes stupid. And when I say our partners, I say we, and you know, we take it personal. But no, it's not you, it's her.
Okay, thank you. If a woman has PCOS and endo and has already had ovarian drilling, would you advise her against her having or doing other kinds of surgery?
So the thing is that I'm so aggressive with endo that I treat it like it's a cancer. Right. So it all depends on how did they do their endo surgery. Right. Like I've gone into the operating room with other surgeons that have done endo, and they say, "Are you going to take that?" I mean, what do you mean if I'm going to take that? If she's your daughter, would you not take that? Well, yeah, but it's a little dangerous. I was like, well, I mean, that's why we train. We train so that we can be effective when we're doing these complex procedures, right? And that's why we have to talk to our patients about the risk, because if you leave the disease behind, next time when you come, it's worse, right? Mm-hmm. So every time we take a patient to the operating room, we have to do our absolute best to make sure that we remove as much disease as possible from wherever it is, and as safely as possible, which is why we focus only on endometriosis. Like the last time I delivered a baby was 2015, June 28, 2015. And I remember to the day. So unfortunately in endosurgery, you have to give up everything else. There's no other life after endo, which is something that my wife tells me very often, apparently, but I believe so.
Okay, what are some of the more uncommon symptoms that occur with PCOS, endo, and adeno?
I'm sorry?
What are some of the more uncommon symptoms that occur with PCOS, endo, and adeno?
Uncommon symptoms or common?
Uncommon.
That is almost impossible to answer in the next hour and a half, because there's so many different things, and it's patient dependent. That is like, that's a trap question, Odelia.
I'm asking the questions as they come in. I don't want them to say I didn't ask their question.
I know. But yeah, so it depends on many different things. Like you can have patients with with adenomyosis that can have like very weird bleeding, or you can have patients that have adenomyosis that have absolutely no symptoms, but just pain. Right. So, and it's good that you mentioned that, because I had a patient, for example, recently that I did her endo surgery and removed everything. She wants to have a child in the near future, but now she actually is able to differentiate the pain from her endo than the pain from her adenomyosis. Why? Because everything is so bunched up together in the beginning that, like, where am I having pelvic pain? And then basically patients go like, where am I having pelvic pain? And then you guys point to here. So it's like, it's in the middle, somewhere here in the middle, which is why I usually tell my patients, can you use one finger to tell me where the majority of your pain is? And they go, here. Just one finger, and well, all these things. So that's why. So it's important to differentiate, but everything is stuck together. Pubic bone, bladder, vagina, posterior cul-de-sac, rectum, everything is together. So it's hard sometimes for you girls to kind of differentiate. So that's just sometimes why we do things in stages. We're going to take care of the bladder and see how you feel. We're going to take care of the uterus, of the endo, of the rectum, of the pelvic floor. And then each thing is a ladder in the road to pelvic health.
Can I just take a quick comment?
Yeah.
When I work with patients, prepping them for their consultations, one of the things that I do with them is do body scans, and I do really slow, specific body scans, and I teach them how to do it on their own so they can better describe where the pain is and better describe, like, give it adjectives. Is it burning? Is it sharp? Is it dull? Because this helps the doctor a lot.
You know something, I think we should definitely sit down and like get a board, like a whiteboard and some markers. I love, like, if patients have come see me, they know that I use a lot of colors to draw stuff on a paper so that they can have that idea of what we're talking about, right? So we should definitely sit down, get a whiteboard, and start basically drawing everything and do it like by spiel to patients, which I got from my beautiful a past colleague, Dr. Young. We worked on a spiel, and it's a beautiful way to explain patients like everything, so that you can have all that information, right? So that you can see that effectively. Now, that being said, one of the things that I tell patients, like, that it's very imperative is that when I talk to them, I'm asking them lots and lots of questions. But again, I am taking my sweet time doing that, because I have an hour, sometimes an hour and a half, just to talk to one person, right? Which is kind of the reason I'm always late for the next appointment, but we'll work on that. Now, what happens? One of the things that I ask patients, so tell me a little bit about your bladder pain. And they go, it hurts. Well, I need details. Like, I'm Latino, I love gossip, I need details. So I want to make sure that they're telling me, like, how are they urinating? How many times they're urinating? Are they waking up at night to urinate? Do they have pain when the bladder is full or after the bladder is empty? After they urinate, do they go 5 minutes later to pee or not? And the second time they go back to pee, does a big amount of urine come out or a little squirt, right? Because it tells me a lot of different information. So if you know your body and you sit down and you write it down, when you sit down with your primary OBGYN, that may not be an endosurgeon, you can go, okay, I have dysuria, dyspareunia, and they're going to go, oh, she knows what she's talking about. Let's pay a little bit more attention to this. Because when you start telling your general GYN the complaints that you have, they have to document. So after years of you saying, I'm having pain with deep penetration, I'm having horrible periods and pain with bowel movements, a light should come up in their mind saying, well, this may be endometriosis. Because you have patients that are complaining of the same things for the last 15 years, but they've seen an OBGYN for the last 15 years. And suddenly, when they're not able to be, like a patient told me today that, well, just because now I can't be a breeder, now is when it's important. Yeah. So it's important to understand that, not just that a lot of the times these patients are found to have endometriosis way later in life, but they're having the same complaints when she was 17, the same complaints when she's now 31. So it's bananas, right? So that's the reason to go at this early so that we can kind of take care of it.
Yes. And the next question, do you know if PCOS, endo, adeno, or fibroids can cause complete change in your pH or cause body odors?
That's an interesting question, but I do not know that one. I don't.
Okay. Okay. And my last present question is, will long-term birth control pills cause uterine cancer and hormonal imbalance?
So that has not been proven anywhere, but basically birth control pills are stopping you from producing your own hormones. So I don't believe that they would cause significant hormonal imbalance after you stop using them. But then again, sometimes when you stop using birth control, your natural cycle or your natural hormonal balance can take a long time to click again. Right? Because imagine that you have what's called the hypothalamic pituitary ovarian axis. So two places in your brain, one place in your and down there in the pelvis that are involved in the production of estrogen and progesterone, right? So when we give you birth control, we're basically doing the following. So the ovary produces two hormones, estrogen, progesterone. Estrogen makes everything grow, progesterone stops everything from growing. Progesterone also, when you ovulate on the right side, that ovary now produces progesterone that tells the other ovary, hey, do not ovulate on that side, because if you do, now we have twins if we get pregnant. So on top of that, progesterone also stops the endometrium from growing inside of the uterus. And on top of that, it goes down to the cervix and changes the secretions in changes the mucus in your vagina and your cervix from stringy, clear, egg white to thick and pasty, right? So that is the effect of progesterone. So if you're not pregnant this cycle, at 2 weeks after you ovulated, progesterone goes to check if there's a baby inside of the uterus. And if there's a baby, progesterone continues. So what are the two things that don't happen while you're pregnant? Number one, you don't get pregnant again. And number two, you don't have a period. Why? Because you are pregnant. Now, after the 2 weeks that you ovulated, progesterone checks to see if there's a baby or a little placenta inside of the uterus. And if it doesn't find it, progesterone goes away. And when it goes away, you get your period. Now, when you are taking birth control, what we're doing is we're kind of interfering in that hormonal balance in your cycle. And we give you a birth control that contains a combination being estrogen, progesterone, or progesterone alone. But what are we always giving you? Progesterone. Why? Because progesterone tells one ovary that you ovulated from the other side, and progesterone tells the other ovary that it was the other ovary. So they both go to sleep. So when your ovaries are sleeping, because of the progesterone that's circulating in your body, right? Because progesterone is produced in two places, in the ovary and in the placenta. But remember the name, progesterone, progestation, pro-pregnancy. So when I give you progesterone orally or an injection or vaginally, I'm tricking your body into thinking that you are already pregnant. So because you're chemically pregnant, now you don't need to ovulate. No ovulation, no estrogen, no stimulation of the endometriosis or the adenomyosis or fibroids or anything in your body. So all that stuff is supposed to quiet down, which it does in the majority of the cases. But now when you take your foot off that blockage, it takes time for the hypothalamic pituitary ovarian axis to sink into gear. So sometimes you use birth control for 5 years straight. And when you stop, then you have 3 to 4 months that you're not going to see your period because the gears have not aligned and the motor is not going forward. So it takes time for that to happen. But depending on how long you were suppressed, you may be able to get your period right away, but you may still be able to not have a period in 6 months, depending on the hormones that you use as birth control. So it's very dependent.
Wow, thank you, doctor. And I know I said I had my last question, but someone sent me a private question on my cell phone. So I would like to ask it before we go over to Kimet and Liz. And the question is, how does one cope with PCOS and early menopause?
How does what? I'm sorry?
How does one cope with PCOS and early menopause?
All right. But it's number one, prayer. Jesus, hold yourself to the holy at some point in life, right? Number two, I don't mean to be facetious, but it's like we have to make a little bit of light of this so that we can maintain our sanity, right? So number one, that. Number two is it all depends on what are the symptoms that are affecting you. Some patients have PCOS and they have a lot of androgens with a lot, which can cause female masculinization with mega clitoris, acne, hair, like in the chest and the chin. So it all depends on what's happening because every patient with PCOS is also different because symptoms are varied. So it encompasses a big thing, but symptoms are very varied. So it depends on what is specifically affecting you. If it's hair, for example, I usually recommend my patients to get electrolysis if it's possible because, or laser hair removal so it doesn't continue because it can continue to get worse. But also we have to figure out how can we treat the PCOS so that the androgens are not that elevated to cause some of these things. We've seen patients that because of shame or fear, they do not go into their OBGYN. They may even not have periods for years. But that's not a good thing because when you have PCOS, you have multiple follicles that are producing estrogen. And that estrogen, right, the body doesn't know what to do with all that estrogen and then switches that female hormone into male hormones. But in the meantime, you have a very high amount of female hormones, estrogen, that's going to hyperstimulate the endometrium. And it only takes one cell to go from a normal endometrial cell into a malignancy. So you always have to be monitoring specific symptoms, making sure that they're having a regular period. A lot of times patients with PCOS, in order to protect them, we have to give them an IUD so that there's constant progesterone inside of the uterus, preventing any changes into a malignancy in the future. Weight loss, exercise, yoga, Pilates, clean eating, it's very varied. So it all depends on the specific symptoms that's affecting the patient, right? But it's important, it's extremely, extremely important to talk to an OBGYN that would listen and that would address your concerns because if when you go to somebody, you're gaslit into believing that no, it's in your head, it's not that bad. And then what happens is that you decide, you know what, I'm not going to go because I'm not going to waste my time. Right. And then what happens is like, you don't want to see that specific provider for whatever reason, but not doing that, it's hurting you because stuff is not getting addressed. And then suddenly you come in and you have mega clitoris because you have so much male hormone circulating in your body that now you have something that that we have to do some surgical intervention to bring back the clitoris to its normal regular size instead of it being like a little finger. So this is the importance of finding a provider that you trust and that believes in you and your story so that they can identify with you.
Yes. When you said Jesus and prayers, I felt that one for the early menopause. Going into menopause at a young age, I need ice, I need an AC, it's a lot.
It's a
But
lot.
there was just a follow-up comment to the person who asked about the birth control earlier about being on continuous birth control. She said that she was on continuous birth control for 14 years and her periods, her periods never returned, but she wasn't menopausal.
She definitely needs to see a GYN and they need to do an evaluation of what's happening to her pituitary hypothalamic and ovarian axis, but also depends on how old the patient is. Right. It's different if she hasn't seen her period in 15 years, but now she's 55, then she hasn't seen her period in 15 years because she started birth control when she was 15 and now she's 30.
Right.
Right. There's that puts a different fear of God in our eyes when that happens.
And before I turn over to Kimet with the Facebook questions, because we do have some on Facebook, but less than we have here on Zoom, so we'll take the less questions first. I just want everybody to know that in the chat, Heather has posted a link for those who would like to have a review with Dr. Colon, and she has posted a link and some comments about that. So you can look in either the Zoom chat or on the Facebook chat for that information. All right, so I turn over to Kimet with the Facebook questions.
Hi, good night, everyone. Just saying hi.
Good night.
We're Facebook
Kimet,
and we
your
have
internet.
some
Uh-oh.
questions. Give me
Uh-huh.
1 second.
Okay,
Hello?
go ahead now. Yes, go ahead. Hearing you better
You hear
now.
me? Hear me now?
Yeah,
Yes.
Okay, all right. So I was saying the first question is, my surgeon plans on ablation of diaphragm, endometriosis. If it's present and small, sorry, is it recommended to have it removed even if it is ablated?
it,
Hello?
I mean,
Oh.
so it all depends on who did the ablation or was it a true ablation. If it's a tiny spot and they were able to vaporize everything, that should be okay, but it all depends on where in the diaphragm was it. Was it on top of the muscle or was it the central tendon or, close to a vessel? Because then it can kind of give you a difference depending on. The best thing to do is review the pictures of the video of the surgery and kind of go from there.
Okay, thank you for that, doctor. We have another question. My question is, endo after a full hysterectomy, after a full hysterectomy still able to attack your intestines? Or is it possible it's lesions from past surgeries? I was diagnosed at 12, I'm 52 and battling bowel issues, which is quite complicated. And just a bit of context, this person has stage 4 endo, and the last surgery was 6 years ago with ovaries removed.
Okay, so the answer to that question is yes, it can. Unfortunately, but it all depends on how much disease they left. They were they able to remove everything, or they had to sacrifice and leave some disease behind. A lot of the times, unfortunately, I have videos of all these corrections when I've seen patients that have these exact scenarios that you guys pose that they leave behind, but I just haven't, like, you know what? I'll make a promise to the group so I can actually fulfill it. I'm going to put a video of me excising a spot in the diaphragm on a patient that had a lot of disease on right under her breast, right? So in this case, she had disease there that was ablated and left there. And then over the years, says, no, I burn it. And 5 years later, then she started having way more pain, and I'll show you what I found. So I'll make a promise to the group. I'll put it in my Instagram today.
Thank you so much.
At some point, so that you guys can kind of take a look at what's left behind sometimes. So that's why I say it all depends on who did your surgery, right? So that's the number one indication. Who did your surgery? Were they an endosurgeon or not? Do they focus only on endometriosis or not? Because it's very different. It's very, very, very different, right? So ablation in the diaphragm, it depends if it's ablated over a muscle or the central tendon. I'm hoping that they did an ablation over the muscle where they can be way more aggressive, because if you ablate into central tendon, you can actually perforate the central tendon and cause a lot more issues. Or it depends if it's actually close to a blood vessel, which cutting that blood vessel would compromise some of the vascularity of the diaphragm itself, and sometimes just cut the nerves as well. So it all depends on many different things.
Okay. 1 second. My internet is acting up again. Okay, so we have another question. Why is ovulation so painful, or ovulating so painful that you can't even move and about to pass out from it? I have stage 4 endo and I'm down to my last ovary and fallopian tube. I also get a weird burning feeling around my ovary area.
Okay, so number one, ovulation. So you have to think about the ovary. Imagine this is the ovary has. What's the best way to explain this? Give me a second. Let's Google this again. Okay, share screen. Boom. Okay, so what do we have here? We have a picture of the vascularity of the ovary. So the ovary basically gets blood supply from two different sides. 80% of the blood supply comes from this side called the infundibulopelvic pelvic ligament, right? Which contains the ovarian artery and the ovarian vein coming from straight from the heart and going back into the heart. Now, 20% of the blood supply of the ovary goes from the uterovarian ligament. This is the uterus, and this white stuff over here is space. So uterovarian ligament, 20% of the blood supply, 80% of the blood supply from the IP ligament. Now, the ovary has two spots where you can actually ovulate, like you can ovulate from the lateral aspect of the ovary, which is your side wall, or from the medial aspect of the ovary, which is the uterus and your bowel. But the ovary should not be stuck to the side wall or the uterus and the bowel on the middle. But what happens is that, unfortunately, because when you develop a cyst in your ovary, you can develop a cyst in the ovary at the bottom, the left, or the lateral or medial part of the ovary. So depending on when you're developing that cyst, the ovary, if it's free on the side that you're ovulating, which is usually the midline, you're ovulating towards the middle. So the cyst is growing towards space. So the ovary can grow and do its thing, ovulate and release. But if you have stage 4 endometriosis, a lot of the time happens is that ovary gets stuck to the sidewall. And when you're ovulating and the ovary is stuck to the sidewall, the ovary is pulling on what we call the wallpaper of the abdomen, which is called the peritoneum. And when it's pulling on the peritoneum is rich in two things: blood vessels and pain receptors. So literally, when she's ovulating and the ovary is stuck, it's pushing, but it's ripping the tissue inside of her pelvis. So that's why it feels so bad, like something is burning, because it's ripping. So one example that somebody explained to me recently, and I'm using it every time when talking to patients, especially their sexual partners, I say, the only way that a man can understand how severe pain from ovulation or deep penetration be when the ovaries are stuck to something is if we take the only way that we as guys can think about the amount of pain is if we take our testicles and we staple them to our legs and then we go running. Because that's what's happening. You guys have your ovaries that are stuck to the sidewall, but you're moving and it's ripping. And then if you're having if you're ovulating, the ovary is pulling from the sidewall because the cyst as it's growing, it's pushing and it's causing all that burning pain and sensation. Sometimes that pain can go down your legs, or you can feel that down towards your butt or lower back, right? Which is what a lot of patients feel like. I have a pain that's shooting straight from the front to the back, and a lot of times it's because your ovaries are stuck together. So doing surgery to remove that can significantly improve the quality of life that you're having. And if she has stage 4 and she undergoes a hysterectomy, one of the things that we do here at the CEC is we basically suspend the ovaries out of the pelvis so that they don't stick back down there as they're healing, right? One of the things that happens is that when you have two things that are healing, but they touch, they fuse. So we try to pull the ovary or do what's called an oophoropexy or an ovarian transposition, which can be permanent in the case of patients having a hysterectomy, or temporary in some patients that are wanting to get pregnant in the future. And we suspend the ovaries outside of the pelvis so that that whole pelvis tissue regrows before we drop the ovaries that have also healed separately, so they don't stick back together.
Wow, that's very informative, doctor. Thank you for that explanation. And it's really, really good to see the approach that you take to helping the patient to heal with suspending the ovaries. That's really informative. We have another question. This one is in Spanish. It comes from Dali. Dali says, Doctor, una pregunta puedes responder en español. ¿Se puede tener endometriosis sin dolor? And she says this because los ginecólogos me han dicho que yo no tengo endometriosis porque no tengo dolor.
Bueno, el dolor es una de las razones principales o de las cosas principales que te pueden decir si una paciente tiene endometriosis o no. Sí hay maneras en las cuales la paciente podría tener endometriosis, pero no necesariamente tener un dolor insoportable. El problema número uno es que el dolor es bastante subjetivo. Tú puedes tener una paciente que tiene endometriosis grado 1 y tener un dolor horrible, y una paciente que tiene endometriosis grado 4 y estar, I'm okay, ¿verdad? Entonces, it's the story. It sounds crazy, but it is, right? Because so it's the story of the frog and the boiling water. If you have a frog and you throw it in boiling water, the frog's going to jump out to save itself, right? But if you put that frog in cool water and slowly raise the temperature, the frog will go, oh, it's a little warm, but I'm okay. Because over time, you get very accustomed to the amount of pain that you're having. So for example, I did surgery on a patient 2 weeks ago that had stage 4, everything was stuck together. And after surgery, she says, oh, I don't need to take any pain meds. And I was like, wait, what? So that immediately I'm like, right, stage 4, chronic pain, the last 15 years, even pain after surgery. She's like, this, I've had worse. Right. So then in her case, she only took Tylenol and Motrin after surgery. With hysterectomy, everything done, ovary saved, she only took, and ovary saved and sutured out of the pelvis, ureter stripped, bowel resected, bowel cut, put back together, Tylenol and Motrin. She was good.
Wow.
Why? Because she was in pain for such a long time. Cuando tú tienes un dolor que es crónico por mucho tiempo, el dolor se vuelve normal. Y hay veces que después de que vemos a la paciente y lo operamos, la paciente dice, I should have done this before. I did not know how much more and how much pain I was until I'm now feeling significantly better.
Gracias, doctor.
Hmm?
Okay, so I think that's it with the Facebook questions. I don't see any more here. I don't see any more here,
Thank
so
you,
we can move on to
Kibet.
the Zoom. Thanks, doctor.
All right, so we're handing over now to
You're
Liz
welcome.
with the Zoom questions, and I see it's been popping off in here. So I hand over to her now.
So many questions. Good luck to me. Okay, so first one's from Tanya, and she says, what's the likelihood of having adenomyosis if symptoms are present and severe, but ultrasounds have always been normal?
So the issue is that, number one, it depends on who's doing your sonogram, and to make sure that they are really, really knowledgeable about how to identify adenomyosis. Because the problem is with adenomyosis, it's very difficult to identify very subtle changes in adenomyosis, especially when the patient is younger. But as the patient's age, adenomyosis become much more prevalent, right? So a lot of the times, sometimes you have to do hysteroscopy so that you can see how the inner lining of the uterus is located. You can have patients that have very little in sonographic indication of adenomyosis, but you go in and they have micro polyps and they have micro holes in the endometrium that can actually cause severe pain because she's actually bleeding into the myometrium, into that junctional zone that can cause a lot of pain. But it doesn't take a lot of adenomyosis to cause a lot of pain, right? It just takes a lot of adenomyosis to be able to see it. But sometimes we may believe that the pain that the patient having is adenomyosis, and because of that, you would recommend for patients to have a hysterectomy. And more often than not, the patients would actually come back with adenomyosis, but sometimes they do not come back. But the pain that they had before the hysterectomy goes away after the hysterectomy, even if the adenomyosis was negative in pathology.
Gotcha. Okay. Next question is from David. Shout out to David. Got a husband in the group tonight. Is the Center of Endometriosis open to consulting with other doctors at other hospitals who are performing endometriosis surgery on best practices?
Yeah, I'd be super open to talk to patients, to doctors in other places, in other countries. In fact, Dr. Sonerva has been so gracious to me to allow me to be able to continue to teach. We've done cadaver courses, teaching surgeons from multiple countries, going to Mexico and being involved with their awesome didactics on endometriosis and complex surgery. Now going to Dominican Republic as well and teaching and promoting education, so that we're actually promoting teaching tips and tricks on how to do basic laparoscopic surgery and some advanced cases as well. so that patients can get treatment even if they can't come to the US or come to us.
And what would be the best way for him to contact you to move forward? That should he message Heather? Should he message you
Yeah.
direct?
Yeah, they can message Heather and we can just all get together and have conversations about what is required and how can we help.
Okay, great. Heather's going to put the information in the chat. Tanya has another question. Is there any additional benefit to doing pelvic MRI prior to a planned surgery?
So there is, but it also depends on where are you getting your MRI. So we have a protocol that we've developed at the CEC, then the protocol that actually copied from an amazing group of doctors in Brazil and in Mexico that do what's called mapping of endometriosis. So basically they get sonograms and the same day they get an MRI, and their radiologists kind of sometimes send us like a color picture of the uterus saying she has this portion of the uterus sacrum is thickened, that portion of the round ligament is thickened. And at the time of surgery, they just blow up that picture that the radiologist drew in color and saying, let's just go look for everything they said and find it. Here in the US, those protocols are not necessarily done, but our team at Northside Hospital is now doing, we got together with them and we're doing lots of different MRIs so that we can actually have access to the images immediately, and they know the slices of the things that we want. So that we're very, very specific. But it also depends on where you get them, because not all MRIs are the same, not the technique that you get everywhere is the same. So sometimes it's cumbersome when we want patients to get an MRI, and we sometimes understand that it's not that easy to have to fly down here, get a full evaluation, go back home, and then have to come back for surgery. But what that does in some specific cases, not every patient, is that allows us to plan for surgery way better. Because sometimes patients come in, and they submit an MRI that was very poorly done. It doesn't have any proper mapping. And then we are in surgery and we estimate that's going to be one way and it's way longer because the MRI was wrong.
Okay. In the treatment of adenomyosis, if the uterus is removed but the ovaries are spared, are there still any side effects similar to menopause?
In the what? I'm sorry, which one is that one?
Treatment of adenomyosis, if the uterus is removed but the ovaries are spared, what are the side effects?
Okay, so the number one thing is no, because when you take out the uterus has no hormonal production, nothing whatsoever, right? When you take out the uterus, you don't lose or compromise your estrogen, progesterone production. Now, that being said, let's be devil's advocate again. Remember the picture that I just showed you about the blood supply to the ovary? So from the IP ligament, infundibulopelvic ligament, you get 80% of the blood supply. The other 20% of the blood supply comes from the uterus. When you do a hysterectomy, you are cutting 20% of the blood supply to that ovary. Most of the time, 99% of the time, that ovary should be way fine. But there are some times where that patient may have abnormal vasculature on the ovarian side of the heart, on the ovarian artery side, and then can have significantly more decreased blood supply to that ovary. And some of these patients can sometimes have premature ovarian failure after hysterectomy, but thank God that is very rare. I'll say this less than 1% of the time.
Okay, awesome. What is the best way to treat a large hole in the diaphragm due to endo? What type of mesh?
So meshes are a good thing to do. It all depends on that's the type of mesh that's used. It's actually decided by the CT surgery team. But I can tell her one thing: whenever we can, we try to suture it together and close it instead of putting a foreign body there. Right? But it all depends on the tension of the closure and how big that hole is. But whenever we can, we try to actually staple the diaphragm together and close it so that we don't have a foreign object. Because when you have a foreign body there, that foreign body can actually spread endometriosis if it comes back easier, right? Instead of keeping it right there. So we want to make sure we want to make sure that patients are doing well, right? And that which is the same thing that happens when you have like abdominal endometriosis and you have to go in and cut out a belly button, but you have a huge hole there. Right. And I think I posted a video of that in my Instagram recently. So you guys, you can definitely go in there and check it out, where I had to cut out a whole belly button out of a patient that because every time she got her period, she was bleeding from it. So the surgeon was like, why don't we just put a mesh in this place? And I was like, why don't we not put a mesh and try to do releasing tensions in the fascia so we can put it together and close it naturally instead of putting a big mesh in this area. So I prefer to not necessarily have to put mesh as possible, but sometimes you just have to.
Right. The next few questions we technically answered already earlier, just through conversation. Someone asked about rib cage pain. Could that be thoracic? We discussed that, you know, depending on where on the diaphragm that you can have rib cage pain. Someone asked about how to investigate diaphragmatic endo. We discussed that. This one, what happens if there's so much small bowel adhesions that it's impossible to see the diaphragm?
I have never encountered that in the last 9 years of my life, that there's so much small bowel scar tissue that you can't see the diaphragm. If the patient does have a lot of scar tissue, there's usually a really slow but tedious way to remove all those scar tissue from the small bowel that are stuck up to the anterior abdominal wall so that you can get there. But it takes a lot of patience and understanding that if you have slight tears in the bowel, you may have to do a couple of stitches to protect it, but you should be able to get to where you need to go. So that's not necessarily an excuse that, oh, you have a lot of scar tissue we can't see.
The next one was from Sarah, which we kind of answered this one already as well. It says, can you have endo in the lungs or chest without it being on the diaphragm? That would be a yes.
Yeah.
Okay.
But it's very unlikely. It can happen. You can have thoracic endometriosis like in your lung without necessarily having diaphragmatic endometriosis, but usually one thing follows the other. The diaphragm itself can actually cause these lesions like I showed you from where we're looking from top to bottom. Those lesions, when you're breathing, they're rubbing against the diaphragm. The diaphragm is rubbing against the lung, and it can infect the bottom edge of the lung. And sometimes you have to do a resection of the bottom edge of the lung or any other fluid or any other spot in your lung that looks like it has diaphragmatic endometriosis of the lung parenchyma.
Question. Rafaelina wants to know when's the next time you're going to be in DR?
So I'm going to be going to DR next week. I'm going on Sunday, and I'll spend the whole week just doing consults because a lot of patients still prefer to do person to person. But I usually tell the patients that it's usually way better to do a virtual consult so that I can assess everything, get all the information I need, and then order all the tests that you do need so that when I see you, I have the test in my hand, I do a physical exam, and we can sit down and make a plan there. Because our consults can be so long that the initial consult is usually talking. Like when I was in St. Louis in Rhode Island, in St. Louis in Missouri, I used to talk to patients for an hour and a half, and they would go and they're like, are we doing a pelvic exam? I was like, no, we're not. We just met.
We just met.
Right. So initially it's just talking so that they can understand what are all the things that are going to happen, come back a second time for a pelvic exam, a sonogram, review of the MRI, and then we can make a plan. Or are we going to do surgery? Are we going to do this? Do we need to go to colorectal, gastroenterology, urology, urogynecology, pelvic floor, pain medicine, right? So that we can have that better idea. So that's why it's so important to always do virtual visits first, and then do a physical visit when I go to DR or when we go to Mexico or other places.
Nai wants to come off of mute to ask her question. So we're done with the questions in the chat. So now you can come off of mute.
Hello, good morning here. I'm assuming it's evening where you are. I just want to ask a twofold question. Basically, I'm 36 years old. I've suffered with chronic period pains from the age of 10, where I've had severe bleeding to the point where I bed completely soaked and everything. In 2019, I had to have a myomectomy surgery in which they found I had fibroids, in which they removed 31. And from that, they found that I had severe endometriosis. My last MRI that I had, they've basically said that I have endometriotic cyst, which is bleeding into the ovary, and what could be possibly a second endometriotic cyst with a small hematocele things. That I have severe adhesions, which is, I'm assuming why I get chronic pelvic pains from my rectum, bowel, all the way to the uterus, and as well as my Douglas pouch being obliterated. I want to know, based on the all of this information, in the future, I do want to have children. So I was advised not to have surgery or take any hormonal medication, because that can send me into early menopause, because my AMH level, my ovarian reserve, is low. But at the moment, I've have a new symptom where I've been having very bad chronic abdominal pain, in which no one can tell me what it is. Some doctors speculate that it might be endometriosis that has spread to my abdomen, reason why that I have very bad abdominal pain. I do want to have a good quality of life, because it has affected me working throughout the years, not being able to hold a job for quite a long time. So I'm sort of in a limbo of whether to deal with the endometriosis first, or based on my medical history, whether I should go ahead in regards of along the lines whether freezing eggs is my best option and then deal with the endometriosis later.
Well, okay, I'm gonna answer that question with some pictures, okay?
Okay.
So let's go. So, okay. So this that we have here, this is basically the posterior cul-de-sac. So imagine that there's a camera in your belly button, and the camera is looking from the belly button to the back of the uterus. This is your uterosacral ligament on the right side, uterosacral ligament on the left side. This is the cervix is here, and this is the top portion of the vagina where the penis or the choice would head. So lateral to the uterosacral, you have your ureter over here, fallopian tube, ovary, and you can see this beautiful fallopian tube, how it is, how pink it is, without a care in the world. So this is your right ovary, left uterosacral, left utero-ovarian ligament, right utero-ovarian ligament, remember? Now, when we're basically pulling the camera back, this is the uterus at the top in this specific picture, which looks a little deformed. It's not symmetrical, right? The uterus is usually symmetrical. Now here, again, we have the rectum down over here, ovary on the left, fallopian tube, ovary on the right, fallopian tube over here, draping, same color. Now, here, let me see if I can get this picture better. In this particular picture, you have what's called a partially obliterated cul-de-sac. Why do I say partially? Because you have your intestines over here that are stuck to the uterosacral ligament on the left side. but not the uterosacral ligament on the right side. You see it over here? Here you have
Yes.
your uterovarian ligament, ovary on the right side, fallopian tube, beautiful fallopian tube draping on the right side. So, but in the pelvis deep down, you can't see the ovary on the left, you can't see the fallopian tube on the left because everything is stuck together. Now, in this picture, again, what are we seeing? The back of the uterus, left ovary, right ovary, left ovary, fallopian tubes, but you see the fallopian tubes here starts really tiny and it becomes bigger, and at the end, it ends in a ball. So this is a blocked fallopian tube. And when this stays like that for a long time, it can actually cause a hematosalpinx or a hydrosalpinx. In this case, these two ovaries are touching in the back, and this is what we refer as hissing ovaries. Now, this is another case on a patient that basically also has the uterus over here, round ligament on one side, round to the other, and the bowel and the intestines are kind of stuck together. But when we continue looking down, we see this. So again, this is the uterus, uterovarian fallopian tube on the right. You see the fallopian tube on the right, how nice it looks? This is the fallopian tube on the left side. This is the hematosalpinx. It's full of blood. Right?
Okay.
So personally, I would not be cautious or slow to treat the disease, because when it gets worse, then we are limited in the amount of things that we can do. Whatever it is, it's always better to treat it surgically early. So if you have hydrosalpinx, that needs to be taken care of. If you have ovarian endometriosis, that also needs to be taken care of, so that we're not only focusing on pregnancy, but what the rest of your life will be, the quality of life of the rest of your life, right? Because you want to have significant quality of life to have a life well lived.
That is my main concern. I think one of the things that's making me confused is that I've been told, don't have surgery because you want to have children. Because if you have surgery, you can't have children.
So that's not,
so I'm a bit
that's
confused.
not correct. So that's not correct. Like, one thing does not mean that having surgeries does not mean that you may not be able to have kids. In fact, the way that I was trained is that for example, where the way I was trained here in CC and how I practiced when I was in St. Louis is that in St. Louis, we were in a religious institution that would not have patients do IVF because of religious reasons. So we have a super high rate of pregnancy rate after endometriosis surgery, because endometriosis causes infertility. So if you treat the endometriosis well, you will be able to get pregnant, depending on the organs that are affected for endometriosis, but we can improve the chances of your natural fertility for a great number of patients without having you to go through IVF, right? But it also depends on how much endo it's in your ovary, which is what I tell patients. It's always better. I'm happier to take back a 2-centimeter endometrioma than a 10-centimeter endometrioma, right? Because you know that the 10-centimeter endometrioma has hyperstretched that ovary to a piece of paper. And then the amount of recurrence that can happen in that ovary is significantly higher when it's just 2 centimeters and you can cut very effectively and leave a lot of good ovarian tissue behind, right? So that's why they say that it may be very difficult for you to get pregnant. But I would not take that as a nice answer, and I would not take that whatsoever.
Okay, because right now the ovarian cyst is 24 mm and the hematosalpinx is 13 mm.
Oh, so that would be super nice to take out. 24 millimeters, it would be super nice and easy to take out before it gets to be like 80 millimeters. Or it's kissing ovary. So I would not take that. I would definitely seek the evaluation for an endometriosis surgeon so that they can take care of that.
We're running out of time. Okay. But if you follow me on Instagram, we can totally I can get you in context. I know the situation in UK is not great when it comes to doctors, so I can help you find someone. And if you want to come to the States, by all means, come to the States and we can help you out. We have one last question that we have to get to, because Shakina is always in our in our sessions, and I want to make sure her question gets taken care of. And this is our very, very, very last one. I was just diagnosed with endo and retroverted uterus. What can be done to manage the back pain? Is surgery necessary when dealing with endo? Should I be concerned about the retroverted uterus?
So retroverted uterus is one of those things that does not necessarily mean anything. So that's not like, there's women that have a uterus that's anteverted or mid-flex or retroverted. It depends on multiple different varies. Now, you can have a uterus that's appearing retroverted that can be stuck posteriorly. But, you know, so which is important to see if we have sonograms from you from way before. And if you have a uterus that was anteverted and now it's appearing that's retroverted, it may be because it's stuck. But retroverted uterus are a normal variant of the uterus. So that's not necessarily of concern. Now, when patients have endometriosis that's actually in the posterior cul-de-sac, uterosacral, pelvic sidewall, right? A lot of that pain that's referred posteriorly, it actually, it's described for as patients as pain that's shooting to your lower back, right? So that definitely warrants an evaluation, and it very likely warrants surgery.
Okay. Yep, definitely. And I know we've got some issues in St. Vincent as well when it comes to pelvic PT. We don't have that yet. I saw someone recommend that. By all means, if you ever have any more questions, you can always DM any one of us who are admins in tonight's talk. You could message Heather, you could message Dr. Colon, you could message me, Odelia, or Komet, and we'll be happy to answer any more of your questions. Thank you so much for everyone coming in tonight. We had a great turnout. We had people coming in from all over the world. We really appreciate you so much. Thank you, Dr. Colon, for even answering some questions in Spanish. Odelia, do you have anything else to close us out for the evening?
No, I just wanted to say thank you again to Dr. We really appreciate you agreeing to this series.
Before we close off, we
sorry.
have 3 more
Yes,
questions.
Komet, what happened?
We have 3 more questions on Facebook.
Okay, make them.
I'll go
brief.
through them really
Let's
quick.
go, because my
Really,
wife's
really
gonna
soon.
kill me, and then I'm gonna have to move in with Heather.
Yes. So
Yeah, we gotta
let's
let
go.
him go. He's got kids and a family, and he hasn't eaten since he left for surgery at the crack of dawn this morning. Thank you all so much. We put our email addresses in the chat.
Okay,
and
okay.
Tanti Elise knows how to get in touch with us. Odelia knows how to get in touch with us. Centerfriender.com. You can find us everywhere.
Yep,
Okay, so you guys can,
much.
for those asking, you can reach out.
Katie, go eat dinner.
Get answered.
Yes.
Answer me. I gotta go, guys, but answer me on send me a message on Instagram. I promise that I'll be as snarky as I've been here talking, and we'll keep moving. Okay.
I'll share it on the
Perfect.
Facebook.
And the
Bye,
only
guys.
Thank
one
you.
last thing we have to talk about is next month. Heather Guidon is my mentor, is going to be speaking next month. So please join us for our final session.
Hope I can follow his lead because he's
Bye,
around.
guys.
Yes. Thank you, everybody. Have a great
Thanks,
night.
everyone.
Thank you, Doctor. Thank you,
Good night.
Heather.
Thanks, guys.
Good night,
Thanks, Dr.
everybody.
Colon. Thank you, Heather.